Well, welcome to our broadcast. I'm your host, Matt Kolnia, and I'm the Executive Director of Digital Strategy for the Providence Digital Innovation Group. As a reminder, the information provided during this event is for informational purposes only. This event does not create a doctor-patient relationship, and any questions or medical advice discussed is not considered guidance on what you should do. For any medical questions, please reach out to your primary care or healthcare professional. Now let's get started. Joining me during this live event is Sarah Vaezi, who is Chief Digital Strategy Officer at Providence, and Derek Street. Derek is the Chief Executive Officer of DexCare and a Providence entrepreneur in residence. So welcome to both of you, and thanks for taking the time to share today.
Thank you.
Thank you.
So to kick things off and just give us some baseline context, can each of you tell me a little bit about your roles with Providence and what you do in those roles? Sarah, why don't you go first?
Sure. Thanks, Matt. I am the Chief Digital Strategy Officer for Providence. So I support the organization in service to our clinicians and our patients to digitally enable and set our digital strategy, in particular as it relates to our consumer-facing digital strategy, so how we present ourselves to our patients and our communities. I also work extensively with other health systems and the startup community to find solutions that may solve our major problems, and we work with other health systems to share our best practices and our knowledge and support them in their digital transformation goals as well. And then finally, we have a great product development team that has been featured on previous LinkedIn Live events that does build technology in the white space. DexCare is one of the third spinout actually that has come about through our incubation efforts. And once that happens, I support our entrepreneurs in residence and our product teams in commercializing those technologies.
Great. Thanks, Sarah. Derek?
Sure. As you mentioned, Matt, I'm entrepreneur in residence at Providence and slated to be the Chief Executive Officer of DexCare once we spin the company out, which should happen later this year. My background is in technology entrepreneurship, so I like to build and grow transformational technology companies, primarily in the healthcare IT space, although I've been involved in others as well. And we'll talk a little bit about how DexCare is one of those companies later on.
That's great. So we'll pull back a little bit to just the baseline topic. So today's event is distributed care and digital health. And I think listeners might be a little familiar with what digital health means, but what is distributed care and how does that relate to digital health? Sarah?
Sure. So if we think about healthcare, over time, it's been very health system centric, and we've increasingly over the years moved toward more patient centric models. The ultimate form of distributed care is truly taking care to where the patient is and how they want to seek care based on their own intents and motivation, and their own preferences, the conditions in which they find themselves. So the best form of distributed care is enabled entirely in a way that is sort of decentralized from the system itself, the health system itself, and presented to patients in their homes, wherever they may find themselves, frankly. And so how it relates to digital health is really technology is the enabler for decentralizing care and pushing it out into whatever venue and whatever modality is most appropriate for the patient, given all of those factors that we just talked about. Matt, you're muted.
I knew it was going to happen. Derek, kind of piggybacking on that, for those who don't know, what is DexCare? How does DexCare fit into this context of distributed care and digital health?
Sure. DexCare is the name of our software as a service platform that intelligently orchestrates patient demand with health system capacity across all modes of care. So we call that access optimization, and it's the key to making digital efforts within health systems work for patients and providers and the systems themselves. It's directly tied to distributed care, and in fact, DexCare was originally created within Providence to essentially deliver on what Sarah had just mentioned within a retail setting. So that's really sort of this care everywhere concept whether consumers need to schedule an in-person visit, but do it in a sort of digitally enabled way, or receive an on-demand virtual visit, or even schedule a visit in their home. DexCare enables all of those modalities for patients when and where they need it, initially in retail, and then now we apply that to multiple care settings within the health system.
And just as a little follow-up on that, could you talk a little bit about the growth between sort of retail and then expanding a little bit farther?
Yeah, so when DexCare was originally created, it was, I think, pretty clear, and Sarah can vouch for this, that the need for kind of, again, what I call sort of this high velocity care that really is available when and where anybody needed it, was really focused in a retail setting. That's kind of where the mindset of a consumer was, the kind that's where they expected to receive that kind of care, as opposed to maybe something that was more complicated and required me to be inpatient or something like that. What's interesting is that with COVID, we found that things that, prior to COVID were sort of check the box things that health systems did to digitally enable their care and would do for other service lines. With COVID, those things have now become strategic and critical to those service lines, because just quite simply, a service line that maybe did a little bit of digitally enabled care prior to COVID, all of a sudden had all of its mix shifted over to that, because clinics just weren't even open or haven't been open, and so many are not. And so there's really been this need that health systems have kind of been forced into, but I think for very good reason, to now make digitally enabled care and distributed care strategic to their organization. And so it's just natural that the benefits that DexCare has been able to afford the retail setting are now to be applied to other settings looking to achieve similar benefits.
And I know I'm not sure how much detail you can give, but can you give some color about how fast that shift happened?
Incredibly quickly. So, I came on board April 1, so right when COVID was rearing its head, and I would say within the first month, we were having conversations with very large health systems about how they were, of course, needing to put out the fires, dealing with the challenge at hand, but then starting to think forward about how they could retool their other service lines to take advantage of this distributed and digital care. And again, that's because they just had to, and are still having to. The situation of the moment is that if you don't have certain clinics open, you don't have irrespective of what service line you're in, you don't have a choice other than to provide distributed care in unique and innovative ways so that patients can get access.
And Sarah, you were seeing this from the health system side, and you've seen this before, and so now the brief after. What was the virtual visit, telehealth, virtual care, sort of, how did that fit into the care model of health systems before, and sort of how does that fit now? I know it's only been a few months, but things are moving quickly.
So prior to COVID, we had a very small percent of our total visits that were telehealth. It was under 1% of all of the volumes in the system and the ambulatory network. And it was primarily in this high velocity setting, as Derek described, within what we call express care virtual. We were seeing 50 visits a day or so on average in that retail setting. And then almost overnight, we saw about a 30x increase to 1,500 visits per day. And that spiked a couple times, once in March, once again in July. And simultaneously, the system put in a significant amount of effort to not only on the high velocity side, but on the ambulatory network side for standard visits like primary care visits and specialty care visits, enabling all of our several thousand providers. I think they went up to 14,000 providers launched on telehealth visits. And we are tracking to do over 1 million visits this year. So that's extraordinary. And it happened very rapidly. it was just on an unprecedented scale compared to what we had seen previously, where we really had struggled to overcome some of the key challenges. We've now stabilized at where is roughly consistent with other parts of other health systems throughout the industry, at around 20 to 30% of our total volumes being telehealth. So it TBD in terms of where that'll settle out in the long run, but it definitely is greater than it was, before COVID. I think the other interesting thing is that Derek can speak to at length and very articulately is that it's not just telehealth in terms of a video visit, which is one modality, but this as we move into sort of this tech-enabled distributed model, there are a lot more options at our disposal. So you can do video, you could do chat-based care, and chat-based care has its own derivations, and you can do scheduled or on demand. And so it really opens up the degrees of freedom associated with how care is made accessible to patients. It also opens up the degrees of freedom for how we think about the business model associated with it. And so it just, there's been, we're kind of undergoing a more holistic transformation that isn't just about, let's do a bunch of video visits, but it's really about matching supply to demand in the way that demand wants to access that supply, in a completely different way than what has been a fairly rigid way of delivering care previously.
Yeah, Derek, talk about that a little bit. We've seen sort of a world in which the mindset, at least historically, has been subbing a in-person visit with a virtual visit as a one-to-one, and that counts as innovation. All of a sudden, we're cracking that open a little bit. What are some new areas in particular that may now be on the table for virtual care?
Yeah. So, to Sarah's point, I think these a lot of the things that are on the table have technically been on the table for quite some time. So video-based virtual visits delivered in a synchronous way are things that organizations have been doing for quite a while now. Asynchronous visits as well, chat-based visits. Some of these are newer than others, but these modalities have been around for a while. What's really changed is the awareness that they exist from consumers, which is sort of the first thing to do. But then I think more importantly, just some experience actually using them now, right? Again, we've all had to, over the last 6 months, start to change behaviors in healthcare and other places that we didn't plan on having to change. And so that's sort of forced behavior change. There's some benefits to that, right? Because we experience things that we haven't before, and some of us then will come out the other side and say, that was a good experience, and continue along with that. So it's not so much in my mind that there's a bunch of new modalities that have been created. It's more that the awareness has increased, and some portion of folks will accept that as a behavior change going forward. That also sets up some challenges as well, because since you've got a plethora of ways you can get access to care, and now more people know about those things, it creates some interesting challenges around getting people to that care and aligning up resources and so forth, as Sarah had mentioned, but we can talk about that a little bit later.
Yeah, and you mentioned whether the experience worked for patients as a key factor. To what extent will patient adoption persist after the crisis, and what are the factors that are going to determine that? Obviously, experience is one of them, but there are many factors here.
Yeah, I think, I'm assuming you're directing me. I think that, so you're absolutely, so first of all, that's the question everybody wants to know. I think that's
why I asked it.
Yeah, I think generally, the industry thinks that it's going to kind of settle out around kind of 20 or 30%, not far off kind of what Sarah had mentioned. We're already experiencing Providence, but who knows? That could be right or wrong. I think what it's going to come down to is you said the key word. It is experience. I think it's all about experience, and you got to unpack experience because it's multifactorial, right? It's not just did I get my problem addressed quickly, but was done at a cost that made sense for both me and the health system. Right, the health system has to think through cost as well in a very big way. Do this in terms of figuring out where they want to direct patients. Was I able to see who I wanted to see? Did I even need to see somebody in person, somebody specifically, or could I just see anybody and dealt with it quickly? Was I able to follow up very easily? Was I able to establish a relationship long term? Did I need to establish a relationship long term? So all of these things and many more go into that experience, and that's what it's going to come down to. There's going to be a certain portion of the population, and I think this is true for consumers and providers, that have this experience that is just better than what they had before, right? I don't, if I choose a certain modality, I don't have to necessarily drive, to go get that care. I can get it delivered more quickly. I can do it at a cost that makes sense for me. And ultimately, what I really want as a consumer is I want my problem to be solved. And on the provider side, I want to solve the problems and ideally not have to learn, 15 different platforms as a way to do that. That's all going to factor into the experience. And, we're going to hit it for some people. And it's going to be more challenging to hit it for others where, what we tend to think of as digitally delivered care, may not be the best modality, right? If I've got a broken ankle, I've still got to go see somebody to set the broken ankle. And so, experience isn't going to be solved that way. But, maybe 20, 30% of people we can hit the mark on those things to provide a good experience. And just to keep in mind, we're all kind of, used to the last 6 months of 90% kind of adoption of digital technologies. I mean, if it settles out at 20, 30%, that's an order of magnitude increase from what it's been before, which is transformational for the industry.
And Sarah, from the health system perspective, you see sort of the full patient experience and their full digital experience and a number of platforms, including DexCare. Are there other factors that from a sort of health system and broader side that you're thinking about when you think about what's really going to drive patients for long-term adoption?
Derek alluded to it. I don't think that the impact on providers as users can be understated or ignored. And in particular, we've now got a vast proliferation of these solutions, including from the large tech companies that are somewhat commoditizing these new-ish modalities or taking them on and bringing them into a healthcare vertical. I think actually Derek had shared an article with our team a couple of weeks ago that said the 265 telehealth providers that you have to know. Imagine if you were exposing your clinicians to that kind of complexity. Ultimately, the clinicians have to be online as well. They need to make their inventory, their time, their services available online. And so that really can't be understated in terms of its important, or overstated, pardon me, in terms of its importance to ensuring that we can kind of drive adoption across the board among both provider and patient users. So that's I think a huge factor. We're also, just as a health system, kind of pushing on, the reimbursement, payment, compensation models, all of those other underlying business drivers that are required to really support telehealth and distributed care. Not just as a infrastructure play, but like a utility, but that's something that really does drive a different kind of experience. I'll give you one example, and we've talked about this in several things that we've published, Matt, that you're very familiar with. Under current circumstances, in a fee-for-service model, our providers would need to conduct about 5 visits per hour to make sort of the same, to net out at an equal rate in terms of reimbursement versus 3 in-person visits per hour. Now, imagine if you had to do 5 back-to-back patient visits dealing with complex clinical issues. That's simply untenable for our providers. And so we really need to wrap around the other enablers like how we compensate our providers, how they get reimbursed, moving them increasingly toward value and outcomes to support this. I think that's another kind of big thing. That's not, it's not a technical issue, but it's very supportive of driving the adoption of the technology.
And Sarah, we mentioned earlier that most hospitals have telehealth services already, some 75% do. You alluded to one reason why that maybe hasn't been as adopted in the past, and that's sort of reimbursement. Like, are there other reasons why it hasn't been adopted in the past, and how are those shifting? And we can go Sarah and then Derek. I know you have some really insight into this as well.
If it's a complicated question and a complicated answer, but if I were to simplify it, I would say there's sort of three categories of barriers that we've historically experienced. They've been around coverage. So does CMS, for instance, pay for or not pay for telehealth and alternative visit types that are not in person? Licensure has been another big one around cross-state licensure of providers and the ability to practice across state lines. So there's been some loosening of those regulations during COVID times. And then the third has been around kind of data privacy and security and HIPAA related concerns. So I believe it was back in March where providers were allowed to some flexibility in terms of what modalities they used. So it was sort of like use your best judgment in terms of using things like FaceTime and other things like that. So some of those are some of the big challenges that we faced, other than what we just talked about in terms of reimbursement, compensation models, and just frankly like the business model in general. But those are some of the big ones.
Yeah, and Derek, how do you see some of those barriers potentially lifting? I know we have temporary lifts on some of our cross-state licensure regulations, some of the privacy regulations. Reimbursement is now at parity. Some number of that may remain post-COVID, some of it won't. What do you see as the biggest steps forward that we could maybe hope for or expect?
Well, there are certainly policy changes, and I don't profess to be an expert of that or really have any ability to predict where those things are going to go. I will say though that I think almost independent policy change. I think policy gets driven by kind of the realities on the ground. At least it should. And I think that it comes back to how can we make this distributed, we'll call it digitally enabled care. So it's not just delivered digitally, but digitally enabled care. How can we make it work, right? It's really that basic, right? And it's got to work for patients and providers and health systems, right? And so we've got to be able to do the things that are necessary to make it discoverable. Sarah mentioned earlier, making their time and availability and so forth available, discoverable. People need to know about it, right? I mean, anybody that they need to know about, and then they need help getting guided to the place they need to go to get care to provide that good experience. And anybody can go to any large or small hospital website today, and you'll see 10 to 15 different ways that you can get care. And to a consumer, consumers don't really know the difference between. I don't often know the difference between, an urgent versus a retail care setting, or should this be delivered in person or on demand or virtually, or do I need to see a specific provider or not? I mean, there are all these choices that confuse, and the more confusion there is, then the less conversion there is to people actually getting what they want. And then ultimately it's got to work for the health system too, right? Like it's got to, we need to deliver this care, enable this care in a way that works for the health system financially and helps them fund the mission, basically. And so I think and we've got lots of ideas on how to do that, and are doing a lot of good work at Providence to solve those problems. But I think as you solve those problems, then policy will follow it, right? If there's a groundswell of patients and providers, in a more normal situation than we're in right now. Right now, everybody's forced into this way of getting care. But when you can legitimately have options and do it in a safe way, I think as we get to that, when you have a large number of people saying, "Hey, this works for me, and this is what I want," then policy will have no choice to start following it. I think the problem in the past it's been a bit of a chicken and the egg, right? If nobody knows about these things and knows how to use them, then why is policy going to change for reimbursement or whatever to force something that not many people are using? Now, you could argue that, well, not many people are using it because policy hasn't changed. But I would say that, we've tried doing this for many, many years pre-COVID to fairly low utilization across the health system. So I think it's incumbent on the industry to help make this valuable and effective for patients and providers, and then policy will come along with it. We've got to take a lead basically in it.
Absolutely. We got a question in the comments, and I know we only have about 5 minutes left, so I want to encourage folks to put their questions in the chat box, and I'll try and do a Q&A for the last couple minutes of this. But another on that, questions everyone wants answered. What happens to telehealth reimbursements after COVID? Does it settle? I mean, right now we're at parity. Do we settle out in the before days where it's 5 visits to 3 regular ones just to get to the right level of reimbursement? Where do we settle between those two?
I would actually posit that maybe it's a different question that we should be asking, which is that do we think that reimbursements should remain at parity, and rather than will they remain at parity? And the reason I ask that, I reframe it that way, is that in most other industries, when we've moved from offline to online, what followed or was sort of alongside that was essentially deflationary economics, which is basically saying, how do you reduce total cost of care in this context, right? And I think that, and whether it's total cost of care or total cost of an episode, in order to bend the cost curve, I think, and this is potentially a somewhat controversial thing to say, is that we can't expect the same level of reimbursement. And that we have to change the whole model to make it work for providers while we also reduce the reimbursement in order to drive down to bend the cost curve. That's how I would think about it. And I know it presents a lot of complex challenges for health systems who are struggling quite a bit since COVID, and it's going to take a long time just for us to all to recover. But I think that's the right answer. And furthermore, it's an offensive strategy because there are a lot of disruptors that are coming onto the market who will be offering these services for a lower cost than what is our cost basis, which is based on bricks and mortar. And so that is, it's just whether we like it or not, that'll happen, and health systems need to be prepared for that. Derek, I don't know if you have additional thoughts.
No, I agree. I mean, I think again, kind of industry thinks, that reimbursement will settle out around, 80% or so if you're kind of looking for a number and endure. But I think you're absolutely right that even if that happens, so maybe it's not 5 visits, but it's still more visits you have to somehow squeeze in to make the economics work, which all gets back to you've got to have a better cost structure to deliver that care, to make it work, which is the right thing to focus on, I think, versus that reimbursement number, because the reimbursement number will be what it is. Just got to drive costs down in order to make it effective.
We got one last question before I think we probably need to start wrapping up. Earlier we talked about how, patients, it's about experience and they've got to be willing to come back, but it's also about access. So do we have the providers who are there and ready to participate? And that Sarah, you mentioned that the impact on providers can't be ignored. How do you measure the impact on sort of the provider workflow or on the patient experience?
So even though this is a question for me, I'll actually let Derek talk a little bit about the provider satisfaction that they've measured through DexCare, because I think it's a real life example of how you can make that experience really great, and how we're measuring it. Derek, do you want to take that?
Yeah, I know we're at time, so I'll go quickly. So yeah, so what we do is we measure patient satisfaction at the individual provider level for each specific encounter. And so you can dig all the way down to how that provider is performing from a satisfaction standpoint at an encounter level, and then roll it all up to a clinical level or things like that as well. And it provides a couple of really important things to kind of get to the question, Matt. One, it's sort of a simple kind of numerical way of answering for the patient. Did they get what they wanted out of that visit? And all things being equal, if you had to choose one number, that's probably the thing to look at to ultimately kind of tie into some of this enduring adoption stuff that we talked about earlier. On the provider side, there is definitely value to get from understanding the satisfaction that the patients are having with it. I mean, everybody wants to do good work. I would say, though, over time, what we also want to factor into it are some of the things that Sarah mentioned earlier. If I'm a provider and I've got to do twice as much work now, or 40% more work, 60% more work in the same amount of time, and I'm not getting reimbursed more for it, that's a bad experience for me, no matter how much you cut it. Now, if I can do that, but I can reduce the workload to treat patients well and provide a satisfying experience for them, solve their problems, and now I can see more patients, but I'm able to reduce my workload by distributing it a bit and having technology take some of the lift and things like that. That's a win for me on the experience side. So ultimately, looking at the patient satisfaction is an important input, but I would also say looking at the things that are going to just naturally drive provider satisfaction or not, like, is this costing me more time, money, or effort to do than what I could before? That's a pretty important thing for us to be looking at and measuring. And I think as long as providers are as long as that's a net positive for them, then they're going to adopt more. If it's a net negative, it's pretty simple, right? If it's a net negative, then they're not. And so it's incumbent, again, I think this all comes back to, it's incumbent on us in the industry to solve those problems for providers and patients. And then kind of, the rest of the things around the edges will follow.
All right, we are at time. Any parting thoughts, Sarah, Derek?
Not for me. I know we're at time, but
yeah.
Right.
Thank you, Matt, and thank you.
All right. Thanks to Derek and Sarah for joining us today, and everyone listening and sending in your questions. To learn more about our initiatives, programs, services, ways to give, or if you're looking for medical care, please visit providence.org. Make sure to follow us on social media at Providence Health System for LinkedIn, Facebook, Instagram, and under Providence on Twitter. Thank you.
Thank you.